السلام عليكم.
Walaikum salam. How are you, sir? I'm
الحمد
Dr.
لله.
Ubad.
السلام عليكم.
دكتور فواز، ازي حضرتك؟ عامل ايه؟
كيف الصحة؟ اهلا وسهلا، كيف
تمام.
حالك؟
انتوا هتقدموا ازاي مع بعض بنفس الكاميرا؟
هو اول وانا بعد ما يخلص ان شاء الله.
طب I need your name to introduce you. How can I introduce you?
My name is Muhammad Ubaidur Rahman. I am
محمد
senior
what?
registrar. Muhammad Ubaidur Rahman. Ubaidur Rahman.
محمد عباد الرحمن.
Yes.
Senior
Senior registrar in NICU.
registrar in which hospital?
And Jabir NICU.
جابر
Jabir Al Ahmed.
جابر الأحمد. One second, let me. Okay. محمد عباد الرحمن.
Yes.
Senior registrar in Jabir Al-Ahmed Hospital in Kuwait.
Yes. Okay.
نعم. مش عارف. الو جستر.
Mute. Is it ready?
No, wait until to get a signal from him.
Okay.
Yes, doctor, you are.
Are we online?
Yes,
Can we start?
yes, we start already.
share screen.
Okay.
السلام عليكم ورحمة الله. I'd like to welcome you in our Grand Round platform. This is episode number 5. Our episode today actually is going to be broadcasted from Kuwait. And as you know that we are trying to move around the middle region area. We started from Egypt, we moved to Emirates, then we moved to Jordan, and this time from Kuwait, and next time will be from Qatar, and the one after, inshallah, will be from Saudi Arabia. So we are actually trying to get the whole region participate in this platform. So first, I would like to thank our speaker today, and I would like to thank Pearl for the management and organizing this meeting with Muwaffaq Shimali and his team. I'd like also to thank all the team that work with Mr. Muwaffaq in preparing this our events. As I said, this episode will be broadcasted from Kuwait. So tonight we will have Dr. Muhammad Ubad al-Rahman. He's a senior registrar and in Jabir Al-Ahmed Hospital. And later we will have Dr. Fawaz also commenting in his presentation. So thank you, Dr. Muhammad, for joining our session today. And the platform is yours. Thank you. You can start.
Assalamu alaikum. Are you hearing me?
Yes, we can hear you. You can start.
Okay, we can start.
But you can share screen, yeah.
Still screen is not shared?
No, it was there. Yeah.
Now it's coming?
Yeah, you need to enlarge it, I think.
Okay.
Can you enlarge it, like, you know, to...
Wait. Try and give me 1 minute, please.
Before it was there, it was nice.
He's talking.
Okay. Okay.
Yeah. Yeah, now okay.
Okay. Assalamu alaikum. I'm Dr. Muhammad Ubaidul Rahman. I work as a senior registrar in neonatology department in Jabir Al Ahmed Hospital, Kuwait. Today, I will present an unusual case of refractory metabolic acidosis. We have patient baby XY, 25 plus 4 weeker, female, weighing 710 gram, admitted to our NICU with initial diagnosis of extreme prematurity, respiratory distress syndrome, and rule out sepsis. Mother having a year of 24, primary gravitas, single pregnancy, issue having type 1 diabetes mellitus on insulin therapy with the pregnancy-induced hypertension on Aldomit. Having history of 1 DK episode 1 week prior to the delivery, and both parents having history of illicit drug use. Mother was admitted in ER with severe preeclampsia, received 1 dose of steroid 5 hours before delivery with magnesium sulfate for neuroprotection. And baby was delivered by emergency section prior to the emergency section without prior rupture of membrane with no risk factor of infection. Baby was flaccid and apneic at birth, so initial step of resuscitation was done, followed by PPV. Baby was intubated for poor respiratory effort, having a core of 4 and 7 at 1 and 5 minutes respectively. Baby was shifted to NICU on conventional ventilation. Course during the first day of life, baby was kept on PTV mode volume guarantee. Baby received 2 doses of surfactant at 2 and 8 hours of life. Umbilical line was inserted, septic screen was done, and she was started on first line antibiotic ampicillin and gentamicin. TPN was started at 80 ml per kg per day. CBC at birth showing TLC of 7.3, neutrals 56, HB 15.8, platelets A185, and retics of 9.55%. BG at birth was pH of 7.26, PCO2 7.6, bicarb 25, base axis minus 2.5, and lactate was 10. At 24, our labs were normal, CRP3, RFT4, urea, and creatinine 76. Our electrolytes were all normal, sodium 145, potassium 4.2, chloride 115, calcium 1.9, magnesium 0.81, phosphorus 1.6, LFT were normal, and total bilirubin 109. These are 2 X-rays done at 2 hours of life and then in 24 hours of life. And this first X-ray 3 was in place, UAC already inserted, X-ray showing grade 4 RDs, and 1 RBJ was 7.3 pH, PSO2 7.8, bicarb 28.5, base axis 0.6, and lactate was 0.3. On this X-ray, we received 2 doses of Surventa, and the second X-ray was at 24 hours of life. Lungs are comparatively improved with still ET, and central line was in place. And BG at that time showing pH 7.31, PCO2 6.9, bicarb 26.2, base axis minus 0.9, and lactate was 2.3.
Excuse me, Dr. Muhammad, just because the units you are using for the CO2 might be different from the rest of us. So this should be multiplied by 7, I think.
Yes. So CO2 was around 50 to 55 millimeter of mercury during the first day.
Yeah, thank you.
During the first week of life, baby was intubated during the first week on PTV volume guarantee, but needed high pressure. So 3rd dose of Surventa was given at 50 hours of life. Baby was extubated to NIPPV on 7th day of life, and the trophic feed was started on 4th day of life, EBM, and upgraded slowly according to the protocol. At 3rd day of life, clinical examination, echo revealed hemodynamically significant PDA. So IV paracetamol was started for 5 days, and after 5 days, echo repeated showed closed PDA. On 5th day of life, UAC and UVC were removed after putting PICC line. This is the X-ray after first X-ray after the 3rd dose of Surventa. Lungs are comparatively improved. And the second one is on 5th day of life after putting PICC line. After this X-ray, we removed UAC, UAC. Lungs are quite better, but still needed high pressure of 25 Pmax with 5 or 5.5 ml per kg. Tidal volume with working pressure of around 22 or 23 with PEEP of 5.5. BJ during that course remained normal. On the start of the second week, on the day 7, and the 7th baby showed symptom of neonatal absence syndrome, as mother toxicology report came already positive for Lyrica, fentanyl, ketamine, benzodiazepine, and synthetic cathetone. On that clinical sign symptom, as well as the report from the mother, we started baby on morphine and gradually titrated dose. Finnegan score was normalized after starting morphine. Trial of weaning of morphine showed rebound symptoms, so it was continued. This is the X-ray on 10th day of life on NIPPV 25/7 pressure, FiO2 25 to 30%, with I time 0.45 and rate of 40. BG was normal, 7.34 pH with the PCO2 around 50 millimeter of mercury, bicarb 18.9, and base axis -6.1, and lactate 1.5. After 1 day of that, on day 11, baby was reintubated because of recurrent apneas and desaturation. Septic workup was collected, and the baby was started on tyrosine and vancomycin. CBC when report came, TLC dropped to 2.57, ENC 1.43, HB was 11.4, and platelet dropped to 16. CRP jumped up to 25, and PCT was positive 2.2. Blood culture came staph hemolyticus after 16 hours of incubation period and was sensitive to vanco and linezolid. After sensitivity came, we discontinued tyrosine and continued on vancomycin. CSF analysis and U analysis and culture sensitivity was done. Both came negative. And we continued antibiotics 10 days from the first negative culture. The second culture came negative after 48 hours after starting vancomycin. During that event, when NGT was passed, there was a resistance of by passing of NGT. So we stopped passing NGT, and we suspected pneumothorax and pneumomycin on X-ray with suspicion of esophageal perforation. NGT was removed, and B was kept NPU for 10 days and covered antibiotics. Contrast study under fluoroscopy was done at age of 21 days, 10 days from this event. Before restarting feed, no contrast leak was found, so we were starting a trophy feed at that time. This is X-ray at day 11 when baby was reintubated, and baby showed sepsis as well as frequent apneas. The first X-ray showing pneumomycin, the air column in the neck as well as on the right side of the chest, as well as later X-ray showing the same picture. At that time, pH dropped from 7.3 to 7.15 and 7.06 in at that time. After 2 hours, PCO2 increased from 8.2, then 10.4, and base axis increased from -5 to 9. So with this PG and the condition of baby, we intubated the patient, gave 1 normal sign bolus infusion over 1 hour. After 4 hours, pH improved to 7.37 and 7.34 later on. PCO2 in the range of 4.7 to 6.2 millimeter of mercury will come around 45 to 53. The bicarb remained normal throughout that course. Base axis increased from -5 to -8 during that event. But after giving normal sign bolus and intubation of the baby, baby improved, and lactate remained the same around 2. This is the X-ray after 1 day of that event. Air is resolved almost, not fully, but quite better at the time, and the vent parameters dropped down. At VG at the time was 7.33 pH, PCO2 5.9, bicarb 23, base axis -2.2, and lactate was 0.7. This is the trend of CBC since that event, and later on, TLC improved from 2.57 to 8.7, HP dropped to 9, and then 11.6 after transfusion of the pack cells. And at that event, platelets was 16, 2 platelets were given at that time, and then the next day platelet improved to 199. CRP was at that time of 25, but then after starting antibiotics, CRP dropped to 11, then 4, and then 3. After 5 days, trial of 5-day trial of extubation to high flow nasal cannula was done, but baby was reintubated due to severe respiratory distress and increased need of fire-2. We did not try CPAP and NIPP because of suspicion of leak in the esophagus. B was managed on the line of PTB volume guarantee moderate setting with 5 ml per kg and working pressure of around 22 to 23 with PEEP of 6. Repeat echo showed reopening of pedia at that time, so second dose of IV paracetamol was given for 5 days, and baby was kept on TPN since day 1 because we only started to feed at day 4. We reached around 20 ml per kg per day at that time. Then we kept baby NPO. On 19th day of life, baby developed blood ETG secretion and increased level of distress. So baby was shifted from PTB to high frequency oscillatory ventilation. Initially, we kept MAP on 13, then reduced to 11 within a couple of hours, and frequency was kept at 10, delta P 24, and FiO2 40%. Within 24 hours, baby was shifted back to PTB volume guarantee and repeat septic screen at time that came negative. X-ray at that time, this is the X-ray 1 day before on day 18. But during that event with the increased high FiO2 requirement and blood secretion, X-ray showing white out, almost white along with the non-holding capacity on bilaterally. We're thinking about pulmonary hemorrhage at that time and managed with high frequency and with baby resolved within 1 day. This is the PGA at the time of event. pH dropped from 7.38 to PCO2 dropped to 7.25. PCO2 increased to 7.7, around 55 to 60 millimeter of mercury. Bicarb remains same 25, and base axis is around -3. It did not change. Lactate start to improve, start to increase at the time from 2 to 4 and then 5. And this is X-ray after 1 day. The pulmonary hemorrhage improved dramatically. After on day 23, we started feeding on day 22, I think so, and within a couple of days, baby started having greenish aspirate. Baby was at that time 1 ml too early, giving almost around 10 ml per kg feed. With the mild abdominal distension. X-ray showed non-specific distended bowel loops with suspicion of neck. Repeat septic screening was negative, only platelets was low. So baby was kept NPO, suspicion of neck with the IV dosing was started. At that time, baby was difficult to ventilate, and there was labile saturation. X-ray show again homogeneous opacity bilaterally. This is the X-ray at that time. There was homogeneous opacity bilaterally with the distended non-specific bowel loops. After 2 days, the next X-ray, lung improved dramatically, but still there is distended bowel loops are there. This is the pH trend for the couple of next days. pH dropped to 7.11 at that time, then increased a little bit to 7.24 and 7.2. PCO2 remained normal throughout that course, but from 3rd week onward, the bicarb start to drop in the range of 15 to 16, and base axis start to increase from -3 to -5, then -13, -10, and -11. And lactate start to rise from 5 to 13, then 9.8 and 8.8. It improved for short time from day 25 to 26, then again rise up. Okay, some from between 4th and 5th week, baby was kept on PTB volume guarantee for moderate parameter. Baby was kept NPO again on antibiotic for suspicion of neck, and baby was still on NPO from the day 1. From the start on the 3rd week, mild lactic acidosis start to occur. It progressed to severe lactic acidosis by the age of 30 days, and lactate was above 20 persistently. We were managing at that time expiry term, was treating with the next stage 2A. Blood pressure was maintained without inotrope during that time, normal capillary refill time, good perfusion. Peripheral pulses was felt, no tachycardia was there. Abdomen was soft and lax, axial abdomen normalized, ball shadow within a couple of days with no blood PR. And baby was sedated with morphine and midazolam infusion. CBC was normal initially, then TLC stopped to drop with the thrombocytopenia. I will show in a couple of next slides on the CBC trend. and CRP was negative throughout that course. CRP trend was 6, 5, 8, 5, 3, and 4, and 9. CBC trend from day 20 to 24, it is within a range of 4 to 5, then dropped to 2.5, 1.9, and 2.9. At this time, the lactic acidosis was severe, more than 18 and more than 20. HB dropped 2 times, 9.9 and 9.1. We transfused 1 time at that time. And platelets remains static around 50 to 55, 57, and during the start of the 4th week, and then at the close to the 30-day, dropped to 29 and 74, then 9. We transfused BD 15 ml per kg at 9 platelet count. During that time, we had 2 episodes of hypoglycemia for which critical sample was sent and GIR was increased to 9. And these were later found out to be related to the blocked PICC line. Baby had swollen lymph at the PICC line insertion site. Then baby appeared to be stable and responding to treatment of neck. However, she was developing severe lactic acidosis out of proportion to the baby's general condition. And during that time, we sent 5 blood cultures which came off negative. Bedside echo was done, which showing normal structure and function. Critical sample was sent during hypoglycemia episode. It came normal. Insulin, cortisol, ammonia, lactate all came normal at that time. Only lactate was in above range 9. Growth hormone also normal. ECT culture was sent to that time, which showing enterovector cloaca and sensitive to tyrosine. Baby was already on tyrosine, and stool local blood was negative. During the time when pH dropped less than 7.1 and bicarb less than 10, we started giving boluses. 5 boluses were given throughout the course, and then infusion started 1.5 millimole per kg per hour. Platelets and PEC RBC have been given when they are in the low range. During the time when baby had white out lung, baby was not maintaining saturation, so we shifted baby to high frequency oscillatory ventilation with MAP of 13 to 14, delta P around 18 to 20, and FiO2 around 28 to 30. Baby remained on high frequency oscillatory ventilation for 4 days, then shifted back to PTV mode. On the day of 30, baby's condition worsened, metabolic acidosis worsened, leukopenia, neutropenia, and thrombocytopenia. Blood pressure started to drop, and norepinephrine was started and treated accordingly. Dopamine was added, and norepinephrine was tapered due to the high lactate level, which is showing progressive refractory high in uncompensated metabolic acidosis with lactate reaching 10. At the day 32 to 33, we gave 3 more boluses and continuous bicarb infusion at 2 millimole per kg per hour. There was coffee-colored OGT aspirate. We were shifted again to PTV mode due to hyperinflation, and tyrosine and vanco was stopped at that time. Due to the clinical condition, we shifted to antibiotic to meropenem and gentamicin, and septic work was sent, which came out negative. And amphotericin B was started, and after sending blood culture, which came negative, so stopped. This is the PGA trend. I'm just going to show you. If you look at day 18 to day 21, pH remain almost normal. But if you see the lactate level, that they start to increase on day 19 from 5.4, 4, then 5.2. And day 23, it increased dramatically from 5.5 to 13.4, and base axis started to increase from minus 4.5 to minus 13.6. It dropped a little bit. It just number is improving after giving bicarb, but when we stopped the bicarb, the lactate and bicarb drop and lactate started to increase. During the time, bicarb dropped from 22 to 15 and 16 range. This is the period trend later on. The base axis from day 30 to day 33. If we look at the trend, is minus 13, minus 11, minus 17. pH dropped even to 7.07, minus 19, minus 18.5, and till that day 33. And lactate, if you see the trend, 9.5, then 13, then 14, then 17, then more than 20. Then at day 34, there's a dramatic improvement of 7.35 pH. PCO2 was 6.7. Bicarb improved from 18 to 27. Base axis dramatically improved from minus 9 to 1.4, and lactate from more than 20 to 14. And during that time, whenever the pH drop and lactate increases, there's increased echogenicity in the lung, and we need to increase the vent parameters. At that time, the pH was 7.19, PCO2 6.2, 18 bicarb, and more than 20 lactate. Within 1 day, alhamdulillah, chest dramatically improved along with the PGA. Now, the question to the audience: what happened to the baby? How did the baby improved? How suddenly lactate and pH improve? Any differential that come into your mind? Anyone from the listeners? Any idea, any differential that comes into your mind? What has really happened to the baby? What was the cause and how dramatically baby improved? Anyone?
Hello?
Yes, yes.
Yeah, going fine?
Yes, going fine. I just want to ask the audience that
The differential
anyone,
diagnosis.
any idea of regarding differential diagnosis? What happened? Why baby has lactic acidosis, and now why suddenly within a few hours, almost it was 6 to 8 hours, within 2 BGs with more than 20 lactate, and the lactate dropped to 12. What really happened to the baby, or what could be the cause of the lactic acidosis in this case? Baby having extreme preterm, managing on the line of neck, with suspicion of sepsis, but till that initially culture came positive, but then all culture were negative. What really happened to the baby? Any idea? Okay, I will move on to the how we approach the lactic acidosis. Lactic acidosis occur with 3 main pathophysiologies. If there is impaired oxygen delivery, like in the case of hypotension, hypolemia, severe anemia, in the form of hypothermia and mesenteric ischemia, or if there is impaired oxygen utilization in the form of if any drug use, and in the form of a baby has liver failure or renal failure or inborn error of metabolism, or baby having severe sepsis, or any deficiencies of thiamine and biotin, or if there is short bowel syndrome, thing like that. So we investigated lactic acidosis in the form of we involved the metabolic and genetic team initially. We thought about the metabolism. We sent urine organic acid, amino acid chromatography, urine ketones, genetic panel for lactic acidosis and ammonia. Newborn screen came normal. Amino acid chromatography was pending at that time. ACTH, the result was pending. Critical sample, I already told you that it was normal. Urine ketones were negative. Urine organic acid result came normal, and genetic study was sent chromosomal DNA banking and genetic panel for inborn error metabolism and lactic acidosis. Result are still pending. Along with that, we sent sample of HIV and CMV, which came negative. Throughout the course of the disease and till now, RFT, electrolytes, LFT, and bone profile remain normal throughout the course, except the phosphate become low 2 times and ALP raised to 600. For that, we supplemented phosphate and as well as increased vitamin D dose to 600. On reviewing the patient record, baby received TPN 34 days. And we reached only 15 to 20 ml per kg trophic feed. And baby was kept on TPN without addition of multivitamin and trace element. So, question to the audience: what trace element on vitamin deficiency can explain this baby's condition? If anybody has in mind, please let me know.
If anyone has an answer, you can write it on the question section, please.
I will give you a few seconds, then I can move on. Anybody? Okay, I will move on. After reviewing the record, we were missing one injection. That is called, we were not giving multivitamin to the baby. When we search the data and literature, the thiamine deficiency can present like this. So we immediately give thiamine 50 milligram per kg IV, and within 6 hours, the pH improved from 7.2 to 7.35, and bicarb from 18 to 27, and base excess from -12 to 1.4, and lactate to 12. After giving bolus, we give maintenance for the next 10 days, and there was a dramatic improvement of the clinical condition of the baby, as well as the metabolic profile. Bicarb increased to 34, then 32, then 24, 27, all normal, and pH even increased to 7.51, and 7.48, 7.48, and lactate within 1 day improved from 20 to 12, then 11.7, then 11, and next day 5.4, and within a couple of days to 1.2. Okay. After that, baby clinically improved regarding the BGA as well as the overall condition, but baby developed resistant status epilepticus the next day. Initially tonic, then tonic-clonic with positive electrographic CFM. We used phenobarbital 40 milligram loading, then maintenance. And along with that, we have to give levetiracetam 80 milligram per kg maintenance, and along with that, we have to add midazolam reaching to 40 microgram per kg per minute. During the status blood pressure drop, needing dobutamine and norepinephrine antibiotic was started when co-marrow septic markers show increased CRP 25 and 33, although blood culture was negative. So and we added B6 and B1 in maintenance. Pediatric neurology opinion was taken and followed in dose adjustment for seizures. CFM show burst passion pattern with multiple spikes and seizure activity. After giving the medication antiepileptic, within a couple of days, the status improved, and we start tapering the antiepileptics. On day 47, from now on, I will just quickly review the patient update till end today, and then we can discuss the topic. From the day 47, baby will become hypotonic, lethargic, septic screen was sent, and we were started in vancomycin and meropenem. Baby was on baby culture came positive on that day, almost 10 to 12 hours, staph hemolyticus. The next 7 culture came positive with same staph hemolyticus, and after that the 8 culture came negative. CRP increased to 98, then kept around this level 68, 75, 63, 98, and then dropped to 42, 13, and 4. Okay, at that time, the TLC was almost normal to 4.8, 5.8, 8.9, 10, but platelets remain normal throughout the course from 37, 42, 27, 32, 94, and 33. We did not transfuse any platelet during that time. And then at around day 73, platelets start to improve to 168. After positive culture, we stopped meropenem, and but due to repeated culture positivity, we added teicoplanin, then septrine, but no response. Then lastly, we added daptomycin, and the culture came negative on that. And the sensitivity of staph hemolytic at that time was vanco and septrine, and resistant to oxypenicillin and teicoplanin. Had ultrasound throughout the course showing grade 1 IVH. And CT scan brain was done after the baby developed seizures, showing diffuse hypodense white matter, likely unmyelinated white matter. MRI is in plan. Baby was activated at on day 48 of life to NIPPV, WIN to an CPAP on 60th day of life, and then on high flow on 80th day of life. Right now, baby is on high flow nasal cannula for liter 21% FiO2. We started feeding, and now baby reached 140 ml per kg per day OGT on low birth weight. And we are tapering the medication. Right now, we was on Kipra 30 milligram per kg and Pheno 3.5 milligram per kg. Along with that, we started on spironolactone 1 milligram per kg and hydrochlorothiazide 1 milligram per kg PT. Okay, now I will discuss the topic thiamine. Thymine is an essential water-soluble vitamin. It is essential for aerobic and energy metabolism, especially glucose. Thymine is rapidly absorbed in jejunum and ileum. There are two different sources of thymine: diet, that include chicken, nuts, yeast, legumes, brown rice, peas, cereals made from whole grain, and other sources, bacterial source in the normal gut flora microbiota. Thymine is actively transported from the gut after absorption. It is phosphorylated to TPP, and thymine is very low in white polished rice. The thymine molecule is denatured at high pH and high temperature. Hence, cooking, baking, canning of some food, as well as the pasteurization, can destroy thymine. It's very rare in developed countries, but can be found in developing countries due to malnutrition. Thymine pyrophosphate is an active form of thymine. Thymine function as a coenzyme catalyst for several biological processes during aerobic metabolism. That is in the conversion of pyruvate to acetyl-CoA, and is involved in other cellular metabolic activities in the form of TCA cycle. In carbohydrate metabolism, glycolysis and oxidative phosphorylation, as well as the branch amino acids. Without thymine pyrophosphate, these processes are limited, and shunting of metabolism will occur, leading to lactic acidosis. This happened to our baby. As body has minimum thymine store, other than liver is no more than 30 milligram total. Other organs that contain thymine include skeletons, muscle, brain, heart, and kidney. The half-life of thymine is 2 to 3 weeks. Due to limited storage, tissue storage, continuous intake is required to maintain normal markers for thymine sufficiency. So high metabolic demand tissue can become thymine deficient in few weeks' time if supply is inadequate. Simon symptom can appear more early if baby is already deficient, or more losses and critical ill baby, or baby exposed to high carbohydrate dose, like high dextrose, as we given in our baby in the form of TPN. When exposed to more dextrose load, as in TPN, it's increased metabolic demand for thymine, as thymine is essential for glucose metabolism. So there will be a relative deficiency of thymine can occur. So the causes of thymine overall. First is insufficient supply, like if we don't give TPN without vitamin and poor supply, or if a baby is breastfeeding and mother having thymine deficiency during pregnancy. The second is diminished absorption. As the thymine is absorbed in jejunum and ileum, and there's dysfunction in that area, the shortcut syndrome or the celiac disease is there. And the third one is increased utilization, as in case of pregnancy, trauma, infection, and alcohol use. It causes more excretion of thymine through the kidney. Thymine and all metabolites are primarily excreted in the urine, and small proportion is excreted in the bile. Now, forms of thymine deficiency. There are different forms. One is acute thymine deficiency with lactic acidosis, that's called wet beriberi. The other is chronic thymine deficiency with peripheral neuropathy, that is previously called dry beriberi. The other is Shoshin beriberi, the fulminant thymine deficiency with cardiomyopathy. The Shoshin is a Japanese word that means sudden collapse. Baby will present with the increased respiratory rate and apnea and circulatory collapse. The other form is Wernicke's encephalopathy. It's also acute form of thymine deficiency involving neurological symptom. If not treated, can lead to Korsakoff syndrome. This Wernicke's encephalopathy is treatable cause. A baby will present, or infant will present with ataxia, nystagmus, and confusion. And if this thing is untreated and there's a chronic deficiency, and the patient will present with psychosis and irreversible neurological deficit will be there. So as in our case, the problem happened with TPN-induced thymine deficiency. So how we define it? If there is a history of TPN for 10 to 30 days, as the baby, the store is maximum for 2 to 3 weeks, maximum 4 weeks. So if we give TPN without supplements, and baby has severe lactic acidosis refractory to massive bicarb infusion, along with alpha keto acid accumulation in plasma and urine, it's a metabolite of the lactate, with the resolution of clinical as well as the metabolic effects within or of following injection of thiamine. This happened to the baby. So we had the baby with TPN for more than 30 days without supplements. Baby had severe lactic acidosis refractory to bicarb infusion, and baby improved dramatically within 6 hours after giving thiamine injection. And if we don't give, the progression of disease and fatal outcome without thiamine support. The wide spectrum of clinical presentation in infantile thiamine deficiency is difficult to recognize due to broad spectrum non-specific clinical manifestation, commonly referred to as thiamine deficiency disorder, that overlap with other conditions resulting in frequent misdiagnosis and mistreatment opportunities, and secondly to lack of readily available and agreed upon biomarker analysis and cutoff thresholds. Early symptoms were non-specific vomiting, lethargy, irritability, abdominal distension. This happened to our baby because of gut atonia is a manifestation of thiamine deficiency. With diarrhea and respiratory symptom, baby had respiratory symptom with weight loss and later on development delay. Seizure, apnea, cardiomyopathy, and lactic acidosis can occur. And in older ages, nystagmus, ophthalmoplegia, motor abnormalities, hypotonia, coma, and later on Wernicke's encephalopathy. Now assessment. The diagnostic laboratory criteria for thiamine deficiency, we can check by different ways, but there's no set limit and criteria. What are the normal limits for thiamine? One is the abnormal transketolase activity or unexplained lactic acidosis. The erythrocyte transketolase activity assay, wherein the extent of thiamine deficiency is expressed in percentage termination compared to the baseline. The normal values is 0 to 15%. And if the value increase from 15 to 25%, that increase thiamine deficiency. If more than 25, it increase severe deficiency. What we can do thiamine or TPP or TDP in blood. Most laboratories now measure blood thiamine concentration directly in preference to the erythrocyte thiamine transketolase activity. But it has a limited sensitivity, specificity, as in severe condition, it will give falsely reduced level, especially in the form of systemic inflammation. And this thiamine level can be affected by the recent thiamine injection. And TDP level can be affected by other multivitamins if you're giving to the baby. TDP decreases with age as well as when HB drops. So we have to rely on all these factors before thinking about the correct result. MRI of this baby can show bilateral symmetrical hyperdense areas in basal ganglia, mammary body, and periaqueductal gray matter. The normal range in literature, what I can found is between 70 to 80 nanomole per liter, that is equal to 3 to 7.7 milligram per deciliter. We can also check urinary thiamine excretion. The treatment, what I found in the literature, that we can give 25 to 50 milligram of thiamine per day for 14 days. WHO recommends we can give 25 to 50 milligram IV stat, then 10 milligram IMR IV for 7 days, and then 3 to 5 milligram orally for 6 weeks. The Canadian recommend 40 to 50 milligram per kg per day for 14 days. The daily requirement as recommended by ASPGON is up to 500 microgram per kg per day maintenance. And American Medical Association Advisory Group recommend 350 to 500 microgram per kg per day. And during birth to 6 months is 0.2 milligram per kg per 0.2 milligram per day, and from 7 to 12 months is 0.3 milligram per day. This is a maintenance dose. Later on, we have to follow motor function assessment, balance and fine motor skills, and psychological assessment, because if thiamine deficiency linger on, this can affect long-term all these factors. These are all my references. If you have any question, feel free to ask, please. Thank you. Assalamu alaikum.
Thank you very much, Dr. Muhammad, for the very interesting actually case, and also rare to occur, I have to say. I've myself never encountered a case like this in during my career.
In literature, there are few studies that the cause is almost the same in neonate. Whenever they are giving TPN without multivitamins, from late 90s till now, in different part of the world, there are case reports that show that whenever they miss this thing, this thiamine deficiency, and we lost a lot of babies because of that also.
Yeah, very interesting actually. Dr. Fawaz will join us now, or he's going to go comment?
Yes, he will join. He will join us.
Now let me introduce Dr. Fawaz Al-Bali. He's the chairman of the neonatal department at Jabr Al-Ahmad Hospital in Kuwait. And thank you, Dr. Fawaz, for joining us tonight. Thank you very much.
Thank you very much. Thank you very much for giving us this opportunity to present this case and to have the discussion around it.
Let me just say that we will the questions will be at the end of the two sessions. So if anyone is interested to ask any questions, please put it in the question and answers section, please. Thank you. Until the end of the session.
Thank you very much. I'm going to start my presentation. So actually, Dr. Ubaid did a great job at presenting the case and also going over the medical or literature review around it. I thought on my part, I'm just gonna explain how did this incident happen. And in this case, as he has mentioned, it was a result of not providing multivitamin and trace elements to the baby. We did start an incident report after this has happened with the hospital management. And I wanted just to share with you some of the aspects really we learned from it and how we could prevent it from happening again. Because actually, in our case, trace elements and multivitamins are available or were available at the time, but they were omitted, by let's say as an error in the procedure. Total parenteral nutrition is a high alert medication, and usually the babies who are the most vulnerable babies in the ICU require it, or those who require it for a long period of time. To have safe ordering, the composition and appropriate delivery process is a complex, and it has many potential site or for errors and risk for the patient. It usually, in most cases, it involves more than one department. Usually the TPN is prepared by the pharmacy and then involves an ICU, and there are different teams who are involved. In our case, it even involved multiple sites. TPN, as I will explain later with more details, is not prepared at our facility. So the aim of this presentation to share our experience, and by sharing our experience, hopefully lessons will be learned on preventing similar errors, whether in TPN or anything else, from happening in the future. So I just wanted to give you first some background information about our facility. We work at Jabr Hospital. So Jabr Hospital is the newest Ministry of Health hospital that opened in Kuwait. It opened in 2018. It went through gradual phases of opening. The maternity and neonatology department opened in 2021. So the first baby delivered was on 14th of March, 2021. So now we're going to be 3 years very shortly. It's a photo of the hospital from the outside. It has around 1,000 bed capacity, and it has all specialties under one roof. During the first year of operation, because the opening coincided with COVID-19, and it was like a perfect spot, location to be used by the Ministry of Health as a COVID hospital, because it's a very large hospital. So for the first year until April 2022, the department was receiving only COVID-19 positive mothers. But then from April 2022, so now we're going to be almost 2 years after the end of COVID, now the government have allocated a catchment area for us. Currently, we serve for around 400,000 people. The neonatology department, the building can facilitate a big number, but we are also going through gradual opening. Currently, we operate 15 level 3 and ICU beds and 20 level 2 special care, we call it special care beds. And usually we're running full capacity, even surpassing these numbers. We have the space, but mainly we have difficulty, which is, I think, is worldwide, with nurses. Currently, there are 31 physicians working at the department, 77 nurses. We have 4 dietitians full-time with us, but we don't have a dedicated clinical pharmacist. Nursing, although number appears to be large, 77, but we still, because of the shifts, we have a low nursing to patient ratio. It's between 1 to 2, 1 nurse takes 2 patients, up to 1 to 4. This is for level 3. For level 2, it's even higher, lower ratio. And we have a relatively big number of new recruits, because it's a new hospital, whether it's physician, nurses, and other team members. The Jabir TPN lab is still under construction. The room is there, but it's we're hoping that expected to operate sometime next year. So since opening, there was an agreement done through the ministry to request TPN from other Ministry of Health hospital. And the way we did it to make it practical and easy is that we've developed a standardized TPN regimen. So with that regimen, we call it Jabir TPN. It just shows here, like, for example, so it says one bag. It's like similar to the ready-made TPNs, is that it's a standardized ingredients, and you run it at different rates per kg, and that will give you different ingredients, as you see in this table. So if the maximum, for example, with our amino acid, will go up to 3.5 gram per kg, and all the other ingredients with lipids separately, giving lipids separately. So the bag is done at one of the other hospitals. It's done as a standardized bag. Once it's done, it has an expiry of 7 days. So they give us the bags without the addition of multivitamins and trace elements, because once multivitamins are added, the bag must be used within 24 hours. That's why they are added in the unit in a sterile fashion by the nurses before handling the bags. During the first year of operation, we were getting our TPNs from Adan Hospital. That's one of the Ministry of Health hospitals. They provided us with all our TPN requirements. And what they used to do, and I include here a photo of one of the bags, they used to write on each bag the doses of additives, the multivitamin, the trace elements on each bag, as you see here. So they write just 2.6 ml or 0.6 ml, so that they're added by nurses before handling. The doses are standardized because it's a standardized bag. It's not by the weight. It's not different for each patient. So it's the same doses for all bags. Then on April this year, the first hospital that we dealt with they had a renovation project for their TPN lab, so they closed for a period of time. So we moved to a different TPN lab. It was the maternity hospital TPN lab. The new lab, the maternity TPN lab, produced for us exactly the same TPN bags, same order. So there was no change with the ingredients, with any of that. There was a very minor change, is that they stopped writing the doses of multivitamins to be added by pen on the bag. So that just small note of how many ml of multivitamins. They stopped writing it because during the communication with the new lab, it was agreed that we are, as always, the ones who will be adding the multivitamins and the trace elements. The doses are fixed for all bags. That's why they didn't see the need to write it, because it's a standardized one. They don't have to let us know, and we've been doing this for a longer time. So that was, I was myself involved into the communication And that was the agreement that we will just add it by ourselves, and that's our responsibility. This was not properly communicated with the NICU nursing staff. There was some break in the communication, who are responsible for hanging the bags in a sterile fashion. So for the nurses, when they started receiving the new bags from the new TPN lab, without doses written on them, they assumed that either they were, we had interviews with them, that maybe it has been already added, so there's no need, or maybe possibly at the time they thought that we were out of stock. We actually did run into out of stock for multivitamins for short periods of time in the past. There is, I think, even a global shortage of that. So for whatever reason it's not written there, there's no order, so they stopped doing that. So as there were no orders by doctors to add multivitamins and no instruction in the bag, they started handing the TPN bags without any additions. The nurses did not alert the physicians about this change when it happened. And also we as physicians, we never wrote an order to give multivitamins or trace elements either in the order sheet. We have an order sheet for our patient or anywhere. Because doctors assumed that this is the usual from the start. So for almost, on retrospect, we discovered that for almost 5 months, none of our NICU babies received multivitamins and trace elements in their TPN. The effect of this lack of supplementation was not immediately apparent. As you know, it's not like your GIR sugars are stable, baby are growing, they're getting all their energy requirements. So you wouldn't feel the lack of it immediately. But in retrospect, after this case, when we reviewed like what's been happening during that period of time, almost five months, we had an increase in number of babies who are typically they were fragile babies with multiple problems, usually extreme prematurity and other surgical problems, that they were developing resistant lactic acidosis. The cause of lactic acidosis was not immediately apparent, and even within our department, we had many discussions that we were seeing more lactic acidosis, and it made no much sense because typically for these babies, they're fragile, they have many issues. Many of them actually coincided with them having sepsis. But then at the time when they develop the lactic acidosis, their cultures are negative. There is no, for example, NEC that could explain it. So it was a kind of puzzle, but we assumed that it could be different reasons. We looked into some explanation, but as you said, even for us, we never seen a case of thiamine deficiency in the past. So when we reviewed cases later, we had some cases what we cannot prove or disprove that it was thiamine deficiency, but highly likely. For example, I'll just share a few of other cases that had similar issues. One of them was a preterm baby, 27-weeker, who developed advanced surgical NEC, which was managed by bowel resection and ileostomy. And then post-surgery, I think around a week after that, developed severe life-threatening E. coli ESBL sepsis. That was treated with antibiotics, and actually the baby showed the clearance of the improvement and clearance of the organism. So had a negative culture, and usually we would give, I think, for 10 days or 2 weeks, antibiotic from the negative culture. Inflammatory markers has improved, platelet count improved. For that case, at the last day of antibiotics, the baby developed severe treatment-resistant lactic acidosis and later passed away. At that time, we were puzzled. We did repeat cultures. They were negative. Abdomen, although the baby had a ileostomy bag, but it doesn't appear to be anything wrong with surgically. we had like the baby was sick, had multiple issue, but at that time, specific time, it was not apparent why the baby deteriorated again. One more infant was, we had a term infant with congenital diaphragmatic hernia. And that baby as well was a difficult case, severe PPHN, and had many episodes of PPHN crisis, difficult ventilation, but also around 3 weeks post-repair, also had severe lactic acidosis resistant to treatment. At the time also, we always do like blood culture, septic screen, but comes as negative. And also we had other patients who developed different degrees of lactic acidosis. And the same, it was something noticed by all our physicians that we have repeated cases of otherwise baby, not septic looking, stable ventilation, negative sepsis screen, other labs, but they would develop lactic acidosis. And it was a puzzle for us. That's why when the last case came, we felt that this is, again and again happening again. So all of us started reading more, trying to see the differential diagnosis of lactic acidosis. Then we came down to know about the thiamine deficiency. So the lack of multivitamin and trace elements subjected many vulnerable babies in the ICU to multiple deficiencies. The most severe is the thiamine deficiency. That's why the message really that wanted to pass to everyone who's attending this lecture, that supplementation with both the macronutrients and the micronutrients are both as important. And that TPNs should always be supplemented with multivitamin and trace elements, and this should not be taken lightly, as we saw within our situation. So when we went through the incident report, is just to see what has happened. We had a system failure. How did this happen? How this could be prevented in the future? And I've explained some of the details of what has happened. But I thought just to end up with this lecture is to go with you over how do we do incident investigation. So this is just, it's an important skill that we should do incident review and incident reporting. So the incident reporting, it's a tool for learning from our experience. It's not a punishment tool. Unfortunately, in our culture, and I'm speaking about our hospital, whenever someone fills in an incident report, they feel that we are looking for punishment or, at many times, actually, incident reports are filled less than they should be because of this. And but that's not the point of it. That's definitely the ministry doesn't, they emphasize that this is just a tool, so we improve the service and improve the safety and quality of our service. So I'll go briefly over just the incident report filling. Usually the first, the first part when you fill up an incident report is that you will describe the problem. So when you describe the problem, you'll indicate the reasons and the contributing factors that caused the event. And it could be different levels. It's not always a blame for someone. There could be an organizational factors, like in our case, it was an organizational factor. It could be individual factors. It could be task-related factors, communication. In our case, we had also a break in communication. Equipment, maybe if the TPN lab was in our hospital, we didn't have this problem. Education, if we're all educated, maybe even nursing staff, about the importance of multivitamin, they would have alerted us that we're missing to give them. And sometimes it's environmental factors. So as in this case, whenever, and this is something we learned about, whenever you have a complex task, especially when it involves multiple teams, like in this case, it was TPN team, pharmacy, which are part of the pharmacy at a different hospital, maternity hospital, the pharmacy in our hospital, and ICU doctors, physician, dietitian. Whenever it's a complex task, that's really a red flag that this task, we shouldn't, do it as other tasks, but we should, we should have like a written protocol, fully explained procedure, and we go over that with everyone so that mistake doesn't happen. It is also for us, in our case, it's a new service, it's a new setup. We don't have the previous experience of that. So this is also, again, a recipe for errors. Communication, we always, we would do better with improved communication. So one thing we did after this incident, for example, we set up just a simple thing like setting up a WhatsApp group where the physician, nurses, TPN lab are all, have a direct communication, and from different sides. For example, that helped with that. And then, for example, we have a TPN protocol in that, it's a standardized bag, when to give everything that. But for example, it didn't go over these steps, and it didn't say that, what we've done after that, we have, we wrote like a notice, like a notice board in the preparation room inside the NICU that no TPN will be hanged without multivitamins. And if it's not available, or for whatever reason, the nurse will need a doctor order to say that it's okay to hang it without the multivitamin. So it's now the other way around. You don't need an order to give the multivitamins, but you need an order to hang a bag without multivitamins. Again, this is some general knowledge. When considering the contributing factor, like when you think about it and analyze it, just to see, like, instead of blaming someone, to say, this factor, if you eliminate this factor, will the problem be eliminated? That's one way of knowing if this is the main contributing factor. And when you write it down, try to write it. The description should be specific things, and objective words, and avoid negative words like they were careless or poorly trained or something like that. But to be objective, we're all learning, and everyone need the instruction and the guidance. If part of it is a human error, try to find the underlying cause. Was it there was no enough education, no enough training, or whatever other reasons? And then in the part of the incident writing, you should describe how this could be prevented in the future. Then part of our incident report that we are using here at the Ministry of Health in Kuwait is we use the severity assessment code. It's called the SAC code. So it is a tool used to determine what actions and what investigation methods should be taken by the organization whenever an incident has happened. I'll just go over it briefly. But for that SAC code, it has 4 steps that you should do. The step number 1 is to determine what consequences has happened, or what are the outcome of the incident. So when you describe, let's say, in our case, in that particular baby, the baby was catched and was supplemented with thiamine, and then the baby did not result in dying. But with other patients, maybe that thiamine deficiency was a contributing factor for death. So it is a serious complication. So this is serious. The next step will be major, so that this is description, not specific for neonate, but for all. So like major will be loss of permanent function. Moderate will be permanent reduction of bodily functioning, minor or minimum. So you'll go over these definitions. That's the step number 1. Then the step number 2 is to say, now this incident that has happened, how likely for it to occur again. For example, you would have to say whether it's the frequent, likely to occur again, possible, unlikely, or rare. And there are some definitions that will help you with that. Rare say, may happen once every 5 to 30 years. So it's a very exceptionally rare circumstances. But if some things that could happen again. So like in our case, now we will, inshallah, never have problem with TPN because now we're all alerted. But for example, what are the chances of some break of communication in an important step, a complex step happening again? If we don't, follow things to do it. I was just thinking for our case, sometimes, medicines, the company concentration changes suddenly and without proper communication. And if you write them, for example, by ml instead of by millimole, that might be, a hazard of this happening. That's why you should always use standardized way of writing, for example, medication. Then the step number 3 is that you will do, they call it the SAC matrix, is that you will do this table, consequences, whether it is serious, major, moderate, and the frequency, and you will assign a score. So score number 1 will be the highest score, the most serious one, and 4 is the SAC 4 will be the least serious. Then the final step is that based on the score you got, that's actually what you should say. Then if the score 1, this is an extreme risk. So the recommendation is that you take immediate action required. You need to notify the organization director, the hospital director, and you do a detailed root cause analysis. For example, the low risk ones, you'll just do a concise analysis and then, inform people. So yeah, it says here, SAC 1, detailed investigation using root cause analysis. SAC 2, in-depth case review. SAC 3 and 4 will be concise investigation. Usually this is just like general information about the incident reporting. What you need as well, you need to have a team that helps you to do that. So, and when you have a team, each one should have clearly defined roles and responsibilities. The team members they have different skills, time commitments, and background knowledge. If you're doing the full investigation, you'll need at least 4 to 5 individuals, sometimes even more, and they should maintain confidentiality. You should never go and speak to people or in corridor to say someone did this or nurses did this or the blame business. The team, once you have the team, they need to gather. You use different sources. Form itself, it has a lot of information. That will be the starting point. You may need to check the medical records, interview the staff. You visit relevant sites and gather also information, supporting information from policies, procedure to know if they were followed or not, literature, consultation with the expert. You will write the timeline of the incident, and then you will identify, they call it care and service delivery problems. The care and service delivery problems are really the problems that cause the safety concerns for the patient care. And as we said, contributing factors. Sometimes you use fishbone diagram, or there's the 5Y tool to brainstorm those factors. At the end, you would develop the recommendations, and the recommendation should, set of recommendation and improvement to tackle the weaknesses in the system that has been revealed, and an action plan. And when you write the action plan, there are different headings. It should include the contributing factors in the incident analyzed, the recommended actions, the required resources to do the actions, and to identify individual responsible for implementing these changes and monitoring the implementation. You should include planned dates for the start and completion of each task, and action should be the deliverables. So things that are available that you could deliver them, and there should be some outcome measure, something measurable. The action plan should be approved by the facility leadership, and there should be people monitoring the implementation of it. One important factor is that you should provide feedback to the staff involved. So that will be that's how you teach them, and it will be a learning process, and that should be given in a timely fashion. And it's important to let them know about the results and the recommendation of your investigation. Thank you.
Thank you very much, Dr. Fawaz, for the very nice presentation. Can we invite Dr. Ubaidur Rahman also? So
yes,
just to address some questions. Yeah, please.
Yes.
Okay, we have some few questions actually for Dr. Ubaidur Rahman. I have something about in your case, was laparotomy considered at any of the stages or no?
No, laparotomy was not, because the abdominal finding was not that significant. Abdomen was descended initially for 2 days clinically, and then improved dramatically. And X-ray showing only dilated gut lobes and then improved. And we managed in the line of neck, because at the time we don't have any other obvious cause of that, thrombocytopenia as well as distended loops. And eventually it was found out it was the lactic acidosis and thiamine deficiency that's playing important role, as thiamine deficiency can cause gut hypertonia. So retrospectively, it was the thiamine that was causing problem as well as the acidosis, definitely.
So you don't think that these abdominal signs that baby presented with was secondary to neck? You think it was related to the thiamine?
No. Initially, when we were managing, yes, we were thought about neck, but retrospectively, going to the literature, it's a typical presentation. The age of presentation of abdominal distension, the gut hypertonia is the one of the presenting complaint of thiamine deficiency, as well as the baby has severe acidosis. The paralytic ileus proceed with it.
Okay, let me just, because I think some of the audiences joined late. I want you to just briefly mention, how did you come with this diagnosis? How did you reach the diagnosis?
Just following the causative factor.
How did you think that this is secondary to the vitamin deficiency? How this correlation was?
You should tell.
Yeah. I would say, alhamdulillah, like we've been reading about it a lot. We had many cases, and just one day I was just reading one article about the differential diagnosis of lactic acidosis, and then thiamine deficiency was part of it. It was just one of the tables I read, and then that just it was like as someone would say, put cold water on me, just to say, okay, are we giving multivitamins or not? Then we discovered that we are not giving multivitamins.
But why the reason we were not giving multivitamins and for this baby for a long time? And usually if the baby in TPN, we put vitamins in the TPN. Yeah.
No, as I explained, since we changed the lab, all babies were not getting TPN vitamins.
Okay.
But it was missed. As I said, it was missed. So not only this babies, all babies.
All babies, okay.
Almost 5 months.
Wow, okay, I got you. Another question for Dr. Ubaidur Rahman. Before you or after you thought maybe it's a thiamine deficiency, I'm not sure if this is available or not, but somebody's asking about the thiamine level. Did you measure thiamine level?
No. Recommendation is that as we don't have any cutoff of thiamine, and during that condition, if you got the normal thiamine level, you cannot really rely on that, because in literature you don't have any fixed numbers at this level is normal, this level is high. So literature says that whenever you suspect, and give it and see the response. Retrospectively, you will see yes, the baby has thiamine or not, because in literature, within 6 to 8 hours, lactic acidosis will dramatically improve and pH will dramatically, as this happened in this case.
Yeah, and I saw the baby really dramatically improve after the supplement
within 6 hours.
Yeah. Yes. Okay. So somebody looks like he doesn't agree with your assessment. He's saying the initial presentation was a fulminant neck. Deficiency usually develop after a few days, so likely it was both. presentation. But you already said.
But the pulmonary neck now just don't present with the abdominal symptom. You will find another systemic finding. Clinically, baby was not that bad. And how it is possible that is pulmonary neck and there's no tachycardia, other things are not suggesting of the pulmonary neck. We thought about it. We managed about on the same line. But later on, for me, it was this misdiagnosis, thiamine deficiency.
Yeah, I would say actually that this is a very good pickup. Looks, Dr. Fawaz, you're the one who picked it up or thought about the diagnosis. A very good catch, yeah. I have a question for you, Dr. Fawaz. How long you been following this incident report? You have a complex system that you displayed in your lecture. How long you been following this?
It does involve. It's been now almost 2 months. We're still in the process, but there were actions that we took immediately. For example, just writing that. Firstly, having communicating this well with nurses. At the same time, educating them about the importance. It was education for all of us, for doctors and nurses, about the thiamine deficiency, how serious it is. Sometimes you think about vitamins, maybe it's like a nutritional deficiency, but now as this, it was something, life and death. So that was communicated very well to nurses, all of them, about these cases. And then we had it's easier for us because it's a fixed doses. So we had the doses very well written and laminated in their preparation room so that this is done. And as a protocol that not a single TPN bag should be hanged without multivitamins unless they get a doctor approval to do that. So there were these immediate things we did also with the TPN lab, the communication between us, and then there were the recommendation. There are things that can help, but sometimes resources or things are slow to get from the management.
Yeah, Dr. Fawaz, are you involved in the incident reporting in your facility, or you have?
Every incident from our department, whatever incident, we have a head of the quality committee in the hospital. But every incident, they will usually call the head of department. Each head of department, the respective head. So in this incident, does involve us, pharmacy department. They were the main two departments, and nursing as well. But I'm not involved as a committee, but as a head of department for things that are related to our department. Yeah.
Is there any advices or any lessons you would say to the audiences, maybe from this incident report system you are following? Is there any advices you would like to give, or any lessons learned recently?
Follow the basis.
Really the big advice, and we still face this problem in our institution, is that people will always say whenever you write an incident report that it's you're looking for punishment, or you're So it's still, although we do have a protocol for incident reporting at our hospital, and it says it clearly, it's not for punishment. And usually the recommendation that comes from it are things to improve the service, to make it safer, and to get the resources needed as much as possible. But still, people, they don't like it. They say, we had so many other incidences that we write it, and there's somebody, even sometimes head of other department, will call and say, please drop it. Don't do this incident report. It doesn't look good on us. But that's not the case. They should, embrace. That's the way we would all learn, and it does help. For example, some they say, just do it internally, but having it through the hospital management, they will give you the resources. They will get everybody attention. When it's sometimes it's documented. People are more, I would say, more, they will be more dedicated to it and to doing the changes, and if we require things from them. So it does help, and for hospital facilities, if they have that system in, it does help.
Yeah, so I mean, what I understand that it's something to correct the system actually, not to punish
Yes.
the individual.
Yes. Yes.
Yeah, and sometimes it is anonymous. Yani, sometimes you do an incident report without really putting
Yes.
a complaint from any name. It's just about the incident itself. Is that correct?
Unfortunately, one thing that we face, we had other incidences that, let's say we have an incident report, and then the recommendation of the committee comes with, not to, state someone, a person, or punish anyone. But then, like by misunderstanding, we have that sometimes with the nursing staff, they will do it as extra by themselves. They still feel that there is that, it reached that level, managerial level, so we have to punish someone, like move someone to a different department. It's as simple as that. But that gives the wrong message, because that incident report happened. Yeah, so you have sometimes to fight with the nursing, for example, as an example, that please don't do anything more. It is required just for a review, and for that changes. If you do any actions based on this, then nobody will report it. It will not help for the future.
Exactly. Yeah. When people see that these are punishment, then they will stop reporting. This is true. Yeah.
Yes. Yes.
Yeah. I don't think I have any further questions. I have some comments about the discussion. It was very nice. So finally, I would like to thank you very much for the presentation. Thank you, Dr. Waidur Rahman, and thank you, Dr. Fawaz, for very interesting topic and very excellent presentation. And we'll see you, inshallah.
Thank you.
Thank you very much. Thank you finally to our audiences who joined us tonight for this event. I'd like to remind you with our other platform. We have the platform of the Grand Round. The next episode will be from Qatar, inshallah. We have also the NeoVirtual platform, which we do it quarter annually. And whoever in Emirates would like to remind you is our ventilation workshop, which will be in January. And our conference, inshallah, the multi-specialty conference will be in May. So, of course, Dr. Fawaz and and Dr. Ubaid Rahman and all Kuwait audiences are invited to our conference. You're welcome to join us, inshallah. And thank you very much again. And thank you for Pearl Management and Dr. Mr. Muwafaq Shemali and his team. See you later, inshallah. Thank you very much for joining us.